Bismillah ar-Rahman ar-Rahim. Today we will have case quiz number 43. Case data: 55 years old male patient presented with fever of several weeks duration with progressive malaise and generalized arthralgia, also with productive cough and hoarseness of voice. There was inflammation and edema of both auricles occurred several months earlier. The patient was addicted to alcohol and tobacco. On examination, we found periods of several hectic fever over 38 to 38.5 degrees centigrade, alternating with periods of subfebrile status. Deformity of the auricular cartilage. It was flabby, resembling the cauliflower ear of professional boxers, but without signs of inflammation. There was a slight saddle nose deformity. Massive crural edema with skin lesions typical of chronic venous insufficiency with no evidence of acute deep vein thrombosis. Disturbed sense of joint position resulting in unsteady gait. Conjunctivitis of the left eye treated successfully with a topical corticosteroid and antibiotic. Investigations showed hypochromic microcytic anemia with low serum iron concentration and elevated ferritin levels. Elevated inflammatory markers C-reactive protein, alpha-1 globulin, alpha-2 globulin, and gamma globulin. White BCs elevated with neutrophilia and elevated platelet count of over 600. And finally, hypoalbuminemia of only 2 gram per deciliter. So, what is the diagnosis? The answer is yes, you are right. The answer is relapsing polychondritis. Relapsing polychondritis. What is relapsing polychondritis? Relapsing polychondritis is a connective tissue disease characterized by recurrent flares of inflammation of the cartilaginous tissue, which was named chondritis, and of other tissues rich in proteoglycans with progressive lesions of the affected organs. The peak morbidity occurs in patients aged 40 to 60 years, although cases of children has also been described. Inflammation may affect the auricular and nasal cartilage, the cartilage of the joints, airways, the media of the arteries, heart valves, sclerotic coat, and ocular conjunctiva. The mean time from the onset of symptoms to diagnosis is 2.9 years, although cases of up to 8 years of diagnostic uncertainty have been reported. The diagnostic criteria for relapsing polychondritis. The clinical presentation is the basis for establishing a diagnosis. The classic work of McAdams in 1976 required that at least 3 of the 7 criteria to be fulfilled. Number 1. Symmetrical inflammation of the cartilage of the auricle and/or external auditory meatus. Number 2. Inflammation of the nasal cartilage resulting in saddle nose deformity due to collapse of the dorsum of the nose. Number 3. Inflammation of the cartilage of the respiratory tract, the larynx, and trachea. Number 4. Seronegative non-erosive arthritis. Number 5. Inflammation of the eye tissues, the conjunctiva, cornea, sclera, or choroid. Number 6. Inner ear of the labyrinth lesions. Number 7. Histological confirmation biopsy of the cartilaginous tissue. Also, relapsing polychondritis may be diagnosed on the basis of one criterion plus typical histological changes or two criteria and response to immunosuppression. In this case, we have symmetric inflammation of the auricle, yes. Inflammation of the nasal cartilage, yes. Larynx and trachea, not sure. Seronegative non-erosive arthritis, plus minus. Inflammation of the eye tissue, yes. You have 3.5 criteria. Inner ear, not sure. Histological confirmation, not done. So our case has 3 sure criteria and the diagnosis was established as relapsing polychondritis. Treatment of relapsing polychondritis. Corticosteroid treatment is the first line of treatment, although not always effective. Immunosuppressive drugs represent the second choice for treatment. Targonska-Shtebinak et al. Described a case of relapsing polychondritis resistant to prednisolone but was successfully treated with methotrexate with a dose of 15 to 25 mg per week, while Goldenberg et al. Reported efficacious treatment with mycophenolate mofetil. When both corticosteroid and immunosuppressive drugs prove ineffective, biological treatment may be beneficial. Gazabon et al. And Kawai et al. Describe successful treatment of relapsing polychondritis patients with infliximab, etanercept, and tocilizumab. And finally, thank you very much for your attendance, and we will see you tomorrow with case quiz number 44. Wassalamu alaikum wa rahmatullahi wa barakatuh.